All right, well, let's get our participants involved again with poll question number 2. And this ECG is a 48-year-old man, has a sudden onset of palpitations. And the options that you have is this ventricular tachycardia, is it supraventricular tachycardia, or is it sinus tachycardia? Okay, just going back to the previous case, Vincent, Dr. Hahn has asked, would you treat this by ringing 000?
Depends on the clinical context. I think, post bypass surgery, very tachycardic. I would certainly think a patient like that should be treated in hospital.
Yeah.
I mean, if he walks into your rooms and he's stable, I think, you don't need to ring 000. You can organize an hospital transport or a relative to take him. But obviously, if you've checked his blood pressure, if he's got hypotensive, got chest pain, or any other concerning symptoms, well, then I think I would definitely, of course, you'd ring 000.
Yeah. Okay. All right. Great. So I think we could probably close the poll now, Penny. Okay, we've got the answers here. 86% of our participants are saying it's SVT. So what do we think, Vincent, with this one?
Well, I agree. It's a narrow complex tachycardia. So you can almost breathe a sigh of relief that it's, when you take the pulse and put the ECG on it, it's narrow complex. It's not going to be a ventricular tachycardia. Of course, a narrow complex tachycardia can be as dangerous as a broad complex tachycardia. And really, it depends what the underlying substrate is. So in someone who's got an EF or ejection fraction of 10%, if they go into a rhythm like this, they're at risk of dying.
Yeah.
Whereas if someone's got a structurally normal heart and no ischemia and they can be in VT all day, they'll be fine.
Yeah.
Certain kinds of VT. So in this case, yes, I agree. It's a supraventricular tachycardia. It's rapid, it's regular, it's narrow complex, and there are no discernible P waves because they caught up in the QRS complex.
Yep. Great. All right. So let's have a look.
Just staying on the case for a little bit longer, there is some electrical alternans. So if you look at the rhythm strip, there's some alternating, the height of the QRS complex is alternating. So that can indicate things like an inappropriate sinus tachycardia or an SVT. And the other thing that causes that is a large pericardial effusion where the heart is swinging towards and away from the electrode with beats and the respiratory cycle. There's also some ST depression. This guy's doing his own stress test.
Yeah.
So he's got some rate-related ST depression.
Yeah. So is there anything that we can do in the surgery to hopefully convert him?
Absolutely. Yeah. So Valsalva maneuvers are very useful. Carotid sinus massages, if you're confident that he doesn't have any carotid artery disease, or any other Valsalva maneuvers are useful to try and revert him. And then in the emergency department, we'd try that first. And if that doesn't work, adenosine usually does the trick.
Okay. Hopefully that answers the questions about the management of that patient. So here's an interesting one. What do we think's going on here?
So if we can just keep in your mind's eye the last ECG, which was rapid but narrow complex, and we look at this ECG and it looks horrible.
Yeah.
So wide complex, rapid ECG. The axis, it's got a leftward axis. It looks like it's a bundle branch block pattern, but of course we're going to call it ventricular tachycardia until we can prove it otherwise. And especially if he's your patient and you know him, he's got a cardiomyopathy, that's what it's going to be 99 times out of 100.
Yep.
And he's got pre-syncope. I mean, your usual ABC resuscitation measures, and think about defibrillator, shocking him out of this rhythm if he is significantly symptomatic.
Yeah, and as you can see by our list here in front of us, Vincent, a number of our participants have volunteered VT.
Yes, absolutely.
Yeah, so they're spot on. All right. Well, Penny, I think it's time for our third poll question. We've got our 18-year-old man who was seen in the emergency department after a football injury. And here's his ECG. Now, the choices that you have are, does this represent SVT? Does it represent sinus tachycardia with left ventricular hypertrophy? or is it pure sinus tachycardia? Do you see many of these presentations, Vincent?
We do see a lot of it, and I think, these days everyone's vigilant. You don't want to miss the patient with hypertrophic cardiomyopathy, or, I mean, that's what springs to mind in a young patient, normotensive, LVH on voltage criteria. You do see a lot of it. Despite the obesity epidemic, there's still a lot of thin people out there. So
yeah. So we've got a pretty even split with this one. Most of our participants are saying just sinus tachycardia, but about a third are saying sinus tachy with LVH. So could you talk us through this one, Vincent?
Yeah, so I think we need to be very very cautious about diagnosing LVH in a young person purely on voltage criteria. You would like to see something else going on to make you believe that there is true LVH. So either ST changes, which may indicate LV strain, or ST changes and T-wave inversion, which may indicate a pathological process like hypertrophic cardiomyopathy. But certainly in a young thin person or a young person under 30, purely going on voltage criteria, I wouldn't, we shouldn't call it left ventricular hypertrophy. It's a normal variant in a young person.
All right. We've got about 6 minutes to go, Vincent. Do you want to sort of pick the eyes out of the remaining cases and maybe go through the ones that you feel are most important?
Yeah, with pleasure. I'll just...
We've had a good range of them so far.
Okay, so here's a patient who comes to the emergency department with chest pain. And this is also one of the, I think it's a lot of it becomes pattern recognition. So we look at the ECG, it looks like sinus rhythm. There's a normal rhythm. He's a little bit tachycardic. The axis is normal. QRS looks normal. There's no pathological Q waves. But what we do see is some marked ST depression.
Yeah.
And in contrast to ST elevation, ST depression is not useful in locating where the ischemia is. So if you see inferior ST depression, it doesn't mean that it's your inferior wall, whereas ST elevation does tell you where the occluded artery is going to be. So ST depression in this setting usually indicate, and if you had a troponin rise, it would be a non-ST elevation myocardial infarct. So at the time this ECG was done, his artery wasn't occluded. Of course, we need to watch these patients very carefully because we know that he can occlude, or he may have been occluded 10 minutes ago and had spontaneous clot lysis on his own, and he could occlude again. So he doesn't have an occluded artery. He does need to be treated in hospital. He's not the kind of patient we'd take straight to the cath lab unless he was hemodynamically unstable. We'd try and settle him with medical management, and then he'd have an angiogram the next working day is usually what we would do.
So would he come into the category of unstable angina?
So if he's got chest pain and ECG changes, rarely it's going to depend on the troponin. If he's got a troponin rise, it's a non-ST elevation myocardial infarct. And if he has no troponin rise, strictly speaking, it's unstable angina. We know now with troponins, and now more recently with high sensitivity troponins, a lot of patients that were previously unstable angina are now being reclassified into non-ST elevation myocardial infarct. And patients with ECGs like this tend to have more diffuse coronary artery disease than in patients who have a STEMI. So he's more likely to have triple vessel disease or double vessel disease.
So I remember from, again, the dim dark past, the differences in prognosis between STEMI and non-STEMI. STEMI having much poorer prognosis, but that's not necessarily so by the sound of it.
Not necessarily so in the era of thrombolysis, but more recently in the era of percutaneous treatment and going to the cath lab, opening the artery, because usually if there's one culprit lesion and it can be treated quickly, we talk about door to balloon times of an hour or less. So from when the patient hits the emergency department to getting to the cath lab to try and get it done within an hour, often they don't have any residual damage and the artery is fixed, whereas patients with non-STEMIs tend to have more diffuse coronary artery disease. But what's more important than door to balloon time is pain to balloon time. So the concern is the patients that sit around at home or get their wives to drive them to hospital and they wait 4 or 5 hours, and by then they often miss the boat. So it's something we need to all educate our patients about. Any concerning chest pain, don't call you in your surgery on a busy day and wait for the call back. Straight to hospital.
Yeah.
Call an ambulance, 000.
Yeah.
So we really try and discourage patients from getting lifts in or driving themselves in or just walking into emergency departments with chest pain.
Yeah. Yeah.
Because, as they say, the interventionists say, time is muscle.
Yep. Yeah. Good saying. We've got time for maybe one more brief one. Do you want to choose between maybe this one and a very common presentation that we see in general practice?
Sure.
Yeah.
Which one would you prefer me to do?
Probably this one.
Okay.
21-year-old woman with palpitations.
Okay, so this is a very common presentation, not only in general practice, but in specialist practice too. So if we have a look at this ECG, looks like sinus rhythm. And the first thing we're drawn to is that we're getting some abnormal complexes coming through.
Mm.
And if you look at the complexes, they're wide, and they've got a left bundle branch block morphology, don't they, Michael?
Yeah.
It's downward in V1 and upward in V6, kind of that William that we were talking about.
Yeah.
So we'll go straight to where the pathology is. So we know it's a sinus rhythm, narrow QRS, but then we're getting some ectopic beats.
Mm.
So ventricular ectopic beats because they're wide.
Yeah.
And we're getting a compensatory pause after the ectopic beat, which is not a concern.
Yeah.
What is a concern is that they're relatively frequent, these ectopic beats. So in 10 seconds, this patient is having 2 ectopic beats. Again, often benign. Most times it is benign.
Yeah.
In certain patients, they can they'll tell you that they've been drinking too much coffee, too many Red Bulls. Alcohol can precipitate it, but coffee doesn't cause this, or caffeine doesn't cause this in every patient.
Yeah.
Alcohol doesn't cause this in every patient. So not every patient will respond to stopping their caffeine.
Yeah.
I think if they're drinking too much alcohol, that means their myocardium is a little bit twitchy and they probably should reduce their alcohol, but it may not respond to simple things. We find that this ventricular ectopy often comes in waves or storms.
Yeah.
And you suggest patients take something like, I often give them magnesium, which I feel stabilizes the membrane.
Yeah.
But often if you give them nothing, it's going to disappear.
Yeah.
Is it normal or not? Well, I once did tell someone that it was normal, and she phoned me back to tell me, no, it's not normal. So I guess it's not normal, but it's very common.
Yes.
And is it something to worry about? Well, it really depends on the frequency of the ectopy.
Yes.
Because in patients who are getting 15,000 or more ventricular ectopics in a 24-hour period, it can cause deterioration of their ventricular function, just like atrial fibrillation can cause deterioration, or just like a left bundle branch block pattern.
Yeah. Yeah.
And in those patients, if their ventricular function is deteriorating, then we should treat them.
Yeah. Mm-hmm.
But we land up in the dilemma: is it the chicken or is it the egg?
Yeah.
So we know that a diseased ventricle can shoot off ectopics.
Yep.
We know that ectopics can cause ventricular impairment.
Yeah.
So what we would usually do is to try and suppress the ectopics, see if the ventricular function improves. And then if the ventricular function does improve, well, I think you've got your answer.
Yeah.
And if you can't manage it on simple medical management, such as beta blockers, then, and the ventricular function has improved, but you're worried it's going to get worse or doesn't, and you can't control the ectopics, then you can consider an ablation.
Yeah. Mm-hmm. I've seen a couple of patients recently after viral infections presenting with frequent VEBs and Bs and even bigeminy, which sort of resolve spontaneously.
Yeah, look, I think when you're unwell from any cause, you get a bit more adrenaline, and that causes a bit of myocardial irritability. I often tell my patients, anxiety can provoke these things.
Yeah.
And if you want to give anyone VBs, put them in hospital, give them a bit of dobutamine or adrenaline, it will happen. But of course, maybe they've got some subclinical myocarditis.
Yeah.
And then myocarditis is another diagnosis that's easy to miss. So it's something to bear in mind. Ventricular ectopic beats can be ablated. And especially when there's a left bundle branch block pattern, it indicates that these ectopics are coming from the right ventricle, hence the left bundle branch block pattern, often from the right ventricular outflow tract. And you can see these are monomorphic ventricular ectopic beats. In other words, they're all coming from the same spot.
Yeah.
So Perhaps it was this patient, maybe it's another patient. I have on occasion organized an ablation for patients with symptomatic ectopic beads that can't be controlled with medical management, especially if their ventricular function starts to deteriorate. So that magic number is 15,000 per 24 hours. So although it's usually a benign condition, if it's happening very frequently, a Holter monitor to see how many ectopics they have, and an echocardiogram to ensure there's no structural heart disease is often very useful. And if patients are symptomatic, I do give them a trial of magnesium or fish oil. But as I said, they tend to come in waves or storms, and they tend to settle down as soon as the stressors settle down as well.
I think that's a great point to finish on, Vincent. Once again, time's beaten us, and we could be talking all night. We've got hundreds of cases here, haven't we? It's a fascinating area, and as usual, I've learned a lot of new information as well. And I'd like to thank you, Vincent, for a very eloquent, clear, and very instructive presentation on ECG interpretations. And I'd also like to thank our participants because, as you can see, we had very high-level questions and some very good answers as well. And thanks also to Penny and the in your college, the New South Wales and ACT faculty, for putting on such a great event. And I look forward to being with you all again at future webinars in the Twilight series. Thank you very much and good night.